Okay, so the next talk that we're going to hear, in this next series, we're going to start describing some of our research use case projects led by the VA-CAUSAL Methods Core. So here we're going to describe both rapid response projects and other use case projects which leverage various sources of VA data. And so first, we're going to hear about how the Methods Core has developed infrastructure to provide rapid response when needed. This infrastructure not only allowed us to generate timely, actionable evidence for COVID-19 vaccines as part of our contributions to the pandemic response, but it also built up the capacity for future public health emergencies. And so to tell us more about these rapid response efforts, I'm delighted to introduce Dr. Hanna Gerlovin. So Dr. Gerlovin is the Deputy Director of the VA-CAUSAL Methods Core at VA Boston Healthcare with expertise in biostatistics and big data analytics. And with over 15 years of data management and statistical programming experience, she has become a key expert in COVID-19 analyses in the VA. Previously, she led the Innovative Analytics section of the Million Veteran Program's Data Core, collaborating on various methodological and phenotyping projects. And so we are so glad to have her here with us today. And welcome, Dr. Gerlovin.
Thank you, Barbara. Thank you, Miguel. Thank you, everyone, for allowing me to come in and make sure I know how to change slides. These are my disclosures. Most importantly, as Dr. Gaziano mentioned, these are my words, my thoughts, my opinions, not those of the U.S. government. And I feel honored to come here today to talk about the last 5 years of my life. I mean, VA-CAUSAL. And it's very exciting. Let me start by saying that our problem at hand was whether we could respond rapidly enough with respect to some questions. I will go on to talk about what it resulted in, and then how we got there. So to start, clinical trials of Moderna and Pfizer in August of 2020 had demonstrated evidence that mRNA-based vaccinations were safe and effective. But there was no head-to-head comparison evidence, no trial data in that regard, and also it was unclear whether these types of findings would be extendable to the veterans population, which is older and has a different diversity distribution than you might see in the clinical trials. To do this, we really needed to identify not only COVID disease outcomes, but COVID vaccinations, potential adverse events that could be captured in the data, and enough information on confounders for adjustment. We needed expertise in the use of VA data and expertise in causal inference, and further, we needed to be able to structure something using the VA's computing resources and infrastructure with respect to data and analytic pipelines. Just to mention, some of the challenges that happened with the computing resources and infrastructure were on everybody's mind at the time of the COVID pandemic. And what I wanted to show here is a little bit about cipher growth. And it is also corresponding to the COVID-19 shared data resource, which was an effort by the Million Veteran Program, by Cipher, which at the time was the VA Phenomics Library, which again had just been accepted as a national program, and VIREC, Vinci, all of the groups came together to start accumulating phenotypes, definitions using both structured and unstructured data. And what happened was between the start of the pandemic and just after, the number of users on this library wiki site just skyrocketed. And this is just new users in the red, just to demonstrate that there was this increase in users right away. Everybody had phenotypes to contribute. And then you see also there's this steady growth of the phenotypes that are being added to the phenomics library for people to be able to use. Oh, you were looking at COVID outcomes this way. How did you define that? Can I find the same thing if I analyze it in my data set? Now, Cypher has had over 2,000 new users between their online and wiki sites in the last quarter, just to give you a scale of how popular it's become. And there's over 6,500 phenotypes on the site. Recently, in 2024, there was a presentation on using VA resource centers throughout the project lifecycle, and this is all just to demonstrate that VA research and resources became extremely collaborative during the COVID pandemic, which really led to the ability to then apply, which one do I press? To apply the target trial emulation framework. So you'll be seeing this slide quite often in the presentations. These are the primary elements of the target trial emulation. And what we were doing was using the VA healthcare databases to emulate the target trial to generate the evidence in the overall population, in subgroups by age and race, across different time periods or COVID strains like the Alpha, Delta, and Omicron viruses, across different subpopulations based on varying eligibility over time, where the COVID vaccine had been deployed, at which stations, and so forth, and also across a possible range of adverse outcomes. And in each analysis, we had to apply this very specific framework, and that required a lot of work, which I'll talk about soon. But let's see where we ended. We ended up with 4 manuscripts, but the 3 of them were looking at these head-to-head comparisons of effectiveness and safety of the primary series of the vaccines, and then a comparative effectiveness of third doses. This is Moderna and Pfizer that we're comparing. We additionally completed a manuscript more recently that was looking at the methodologic differences between doing a test negative design and the target trial emulation cohort design. And it was a very interesting study, but not the point of this talk. From data construction to analysis, we had to build an entire structure. And I just want to express that we started this project, Barbara conceived of the project in September of 2020. We first got access to the data workspace in April of 2021, and this New England Journal of Medicine paper was accepted in September of 2021. The speed of research at the VA doesn't move that quickly, so this was quite an accomplishment for us. And what was even more incredible was that we then did it for both the safety and the third dose manuscripts, and we were able to leverage the same exact data structure and pipeline. So just to talk about what we found in these studies, the first study, we showed that the absolute risk was low of COVID-19 outcomes if you were to get vaccinated. There were slightly lower risks for COVID-19 outcomes for the Moderna mRNA 1273 compared to the Pfizer BNT 162b2 vaccine, and that really either one would be equally effective at preventing COVID outcomes. A quick aside to orient you on the slide, you'll see these dimension badges and altmetric badges, and those are just to kind of show the impact that it's had in the public sphere. Dimensions typically deals with the citations, and altmetric is the other places you might find mention of the publications. And all of this was taken from a really nice dashboard called VA Dimensions. The second manuscript looked at the comparative safety, and we looked at similar time points as in the primary analysis. We extended it because we were looking at safety events across different times. So if you can imagine, each adverse outcome required us to specify the eligibility criteria with respect to being free of that outcome prior to the analysis, which was a data feat in it of itself. And we found that both of these vaccines were looking at low risks of events. Moderna had slightly fewer events per 1,000 person days, and but mostly these were the same. Sorry, I'm just, okay. Third paper that I'm just going to mention, it took the same analytic approach as the first paper. We were looking at third doses of the vaccine received. This one was particularly challenging because the deployment schedule for third doses was very staggered, where certain individuals were eligible between October and November of 2021, and then other people became eligible later on. And so we needed to adjust our eligibility criteria to be able to account for the daily change in eligibility per person. We found, again, evidence for lower risks of COVID-19 outcomes for the Moderna third doses versus Pfizer. And I'm going to move on to the part I really like talking about, which is how we got there, how we put it together. Let me start by the flow chart. The flow chart is very crude. It's a schematic that I drew for a meeting one day to explain how the data was flowing. And there are reasons that the data was organized in this way, and this was primarily to allow for flexible analyses, because if you don't have the information constructed on millions of rows of data the first time around, then you have to do the same data pull again and again. So we've come up with a way to connect the metadata, which is how everything is brought together, look at each data source that has data in it that might be relevant, use Cypher's phenotyping strategies, so as much as possible reuse what's already been developed. But then here we're trying to showcase how to make it reproducible. So my little engine is now going to, whoops, sorry, all these pictures. Is now going to the mechanic, and we're going to upgrade it for use in future rapid response projects. And not just rapid response projects, projects that deal with potentially dynamic treatment strategies, projects that require us to bring together alternate sources of data that might live across different servers. And so what we have now, just to visualize it, we've put together a network that allows us to identify programs, which are circles, in different programming languages that might exist on different servers. We have phenotypes that are predefined in a light blue square. We have data that's coming from sources in other colors of blue and green. And we have project-specific data here that's being mapped in purple, meaning that that's coming out of the pipeline somewhere. And the goal of this is to be able to more quickly address the changes needed when you're revising your eligibility criteria, revising how you're defining your target trial framework, because having that flexibility, knowing what data is out of date, especially during the COVID pandemic, is so critical. And I'm really excited about the stuff that we've been working on lately. So in conclusion, the VA was very well positioned to answer rapid response questions during the COVID-19 pandemic. We were able to leverage existing phenotyping efforts and computational resources to allow for the timely extraction of all elements needed to analyze questions. We've used the lessons from that we've learned to pave the road for more optimized data engines and rapid response activities, as you'll hear about from my colleague, Catherine. And we really hope to be able to do this forever if we can. So thank you very much to all of the people that I worked with, that I work with now in the group, to the CAUSALab for including me as part of your team, And yeah, I'll take questions.